Started just in the interest. Thank you, Fran. Well, welcome everyone. You've made it almost to the end of the term, so that's wonderful. Thank you for being here. It is our last Translational Epi seminar of the year, but we do have a good lineup coming up for the fall. So for those of you who are still going to be around, please watch out for announcements for the series coming up in the fall. And I am actually going to hand it over to Dr. Keri Althoff, who's going to do the intros for our speaker today.
Thanks. Hey, hi, everybody. Thanks for coming online and in person. So today it's my pleasure to introduce Dr. Parastu Kasaie to all of you. She's been in the department for a number of years now, and I got to know her when I got a grant to put together a compartmental model of aging with HIV in 2016. And I still can't figure out exactly why they funded me because I have zero modeling experience at the time, right? And so, for about 2 years, I really struggled to try and figure out how to do this and get it together. And that's when I met Parastu. And she really put a cape on and saved the day with this project. So turns out compartmental model is not quite the right fit for what we wanted to show, because people, when they age with HIV, they oftentimes become very medically complex due to a combination of factors, including the virus itself, the early versions of treatment that we had that caused some mitochondrial dysfunction, and then the longevity of that over their aging process. In addition, there are a lot of different risk profiles of persons with HIV, which is a heterogeneous group of people in the United States, including persons who do and do not use drugs, men who have sex with men, women and men with heterosexual contact, et cetera. So it's really became very complicated, but we could afford the complication with the data that were at our fingertips through the NA Accord, which is a collaboration of longitudinal cohort studies in the United States and Canada. So we were able to use that data and Parastu's brilliant mind to put together an agent-based simulation model of aging with HIV that we believe really captures the medical complexity of aging with HIV. But it's really Parastu who brings the questions for us every time that says, what do we do with this output from a model? How do we make it important? How do we impact the lives of persons aging with HIV? So we're so fortunate to have her. We just resubmitted an application to keep this model going and actually expand it through a brilliant hybrid approach that Parastu led the way on this grant to look at the social determinants of health, how they're intersecting with our 15 subgroups of persons with HIV that we model in the United States, and to bring it all together with collaborations with other modeling groups, right? So very innovative, and Parastu is the link and the brain power behind all of it. So I'm so pleased to have her on the team. She really is an excellent collaborator and just brings a wealth of knowledge and wonderful curiosity to everything that we do. So without further ado, Parastu will talk to you about the forecasted burden of comorbidities and multimorbidity and people with HIV in the United States.
Hello, everyone. Thanks for that very kind introduction, Keri. And I feel like that was a very good summary of everything we do. I can't just skip to the result, but I will bore you for a little bit before that. So I'm Parastu Kasaie. I'm an associate scientist, been here for about 10 years. Disclaimer about, this is all the research of our team and not necessarily NIH perspective on aging among people with HIV, but also the personal disclaimer, as Keri mentioned, I'm an engineer and data scientist by training, epidemiologist by practice. Happily, Keri is in the room. So if you have clinical questions that are outside of my expertise, she'll be the one hopefully answering them. I wanted to touch base on some of the principles of translational epi by the fact that this is offered in these series, and then I will touch base on these throughout the talk and at the end. This was a nice exercise for me to see how we've highlighted some of these areas in our current study, and especially like in the new R01 that we've submitted. This includes like priority areas starting from scientific engagement with public health, which basically entails choosing the right question that has to do with individual and population health benefits and choosing the appropriate methodology to answer that question, which means we should have the capacity to validate and generalize that finding beside the scope of the study. And then having, the contact with public health officials and the audience of our work will be using these results, thinking about education for practitioners and again, decision makers who may be using our results down the line, thinking about implementation issues, what sort of interventions we are considering, what are the evaluation criteria for those interventions in practice, and finally getting in touch with the community to understand their needs and better resonate those in our studies. And we've tried to do a little bit of that so far, and more of that we will be doing in the future. So with that in mind, I will start with a quick survey of, available data to tell you why we started thinking about this question and why it's an important question. Why do we think about comorbidity burden among people with HIV? Now more than ever, this population is aging. Thanks to reformulation of like ART regimens and earlier ART initiation, we are seeing great survival among this population, reaching a life expectancy close to people without HIV. That's all good news. And we've made headways in number of diagnoses, continuing to decline over time, but the size of population living with diagnosed HIV is still increasing. So we haven't reached that threshold that we see decrease in prevalence. And this population is aging. So if you look at the blue lines, you'll see the age distribution over years, comparing about 9% of people with diagnosed HIV over the age of 65 in 2017. Now they're up by 14% and it's continuing to increase. And as people with HIV age, they undergo, they experience risk of non-HIV related comorbidities due to aging, especially because of HIV infection. They experience risk of accentuated aging, which means that there is a one-off increase in risk of comorbidities at the time of HIV infection, and it grows over time. For example, in case of like bone fracture, as you can see, people with HIV has this increased risk of bone fracture as they age over time. And there is, on top of it, there is accelerated aging, where basically the difference is risk itself is increasing over time. So as they age, they diverge from people without HIV. The drivers of this increased rate of aging and increased risk of comorbidities as population with HIV age are diverse, from HIV itself to ART toxicity to a wide area of risk factors that has to do with the HIV transmission as well, and also risk of different comorbidities, tobacco, alcohol, and drug use itself, and also social determinants of health that both affect the risk of HIV transmission and also health outcomes among people who are living with HIV. So in this context, we know there is this silver tsunami of people with HIV that is growing in size, and they're aging to older decades of life. They are experiencing increased risk of comorbidities, which affects their health span and also their future healthcare utilization. So in preparation for all of that, we asked three key questions. What is the future size and age distribution of this population living in the US to 2030? And remember, this was a grant that was submitted and funded about 6 years ago. So back then, 2030 was a long time. Now we are hoping to project future outcomes to 2040. What is the future prevalence of comorbidities among this population? And most importantly, what are the disparities among the key subgroups? Thinking about, subgroups of age, race, and also HIV acquisition risk groups. To answer these questions, we came up with this approach, as Keri mentioned, to develop an agent-based simulation of people aging with HIV in the US, the AKA PAIR model, standing for Projecting Age and Multimorbidity and Polypharmacy among people with HIV. So, and the basis of agent-based model is basically projecting outcomes for simulated agents representing persons living with HIV in the US. This model is informed using wealth of data coming through NA Accord, which is a cohort study of over 200,000 individuals aging with HIV in the Northern America. And given the large size of this cohort, we were able to subcategorize our population into 15 category by 6 different, like 3 races, and the risk groups for MSM, IDUs, and heterosexuals. So I will walk you through the construct of the model from like a very high level perspective, but everything I'm talking about as far as methodology and data sources and assumptions has been laid out in full details at the Pearl website, which I'm including the link here. At the heart of agent-based models lies this computer simulated agents, and our goal was to design these computer agents to reflect the medical complexity of people aging with HIV, which means that we need to capture all of their attributes and characteristics that is relevant to process of aging and is driving the risk of different comorbidities as they age in the model. So these include information, for example, on year of ART initiation, their age and CD4 at ART initiation, and also updating their CD4 count as they stay on ART or go off ART over time to drive their mortality estimates. The model itself starts back in year 2009 with a population of agents who were receiving ART at that year. So the size of that population for the 15 subgroups was estimated using CDC data. And then we leveraged data from NIH report to characterize their age distribution, CD4 distribution, and prevalence of risk factor and comorbidities. Then the model follows this population over time, running in time step representing 1 year. So at the beginning of each year, a new cohort of people starting ART enter the model. The size of this population was estimated using CDC reported number of diagnoses and projecting them with different assumptions to the future. And then their characteristics as far as the age distribution and the CD4 count at ART initiation, and also prevalence of different risk factors and comorbidities was estimated from NIH report. All of this information goes to the heart of simulation model, where individual agents experience risk of different events. They age at each time step for 1 year. They experience incidence of new comorbidities. They experience risk of death depending on ART engagement. And based on that, they start on ART, but they can disengage and re-engage back in care over time. So for the comorbidities I'm mentioning, we basically consider 3 main risk factors driving risk of comorbidities based on our a study of NIH data. This included the smoking, BMI, and Hep C infection. We included 2 mental comorbidities that are most prevalent among people with HIV, including depression and anxiety, and 7 different physical comorbidities, including hypertension, metabolic diseases such as diabetes, hyperlipidemia, and CKD, and also 3 later stage diseases, cancer, MI, and ESLD. And the order of these risk factors and comorbidities is basically informing the relationship to each other, because risk factors are basically driving the risk of all of the comorbidities, and like mental and physical comorbidities, metabolic disorders are basically driving the risk of later stage comorbidities. Here is a big crowded table listing all of our definitions for these risk factor and comorbidities that we use to extract the information from NIH court. And it's included in our website as well. We leverage access to EHR data sets and also patient-reported surveys to identify the first instance of diagnosis for each of these diseases. And there is a distinction here between what I will refer for the rest of this talk as incidence of comorbidities and what our data here reflects, because by the fact that we are only able to recognize the first event of diagnosis, we are blind to that initial period where patients may have been diabetic, but we didn't have any measurement of their blood glucose, and there were no tests before that. So our first window is when the patient is diagnosed or is receiving medication for their diabetes in NIH data. And we are defining it as an absorbing state. So we are only talking about patients with a diabetes diagnosis, regardless of their treatment status, because it's an underlying condition as they age. They need to continue receiving treatment for it. So how did we use this data to inform incidence functions? It's basically through a web of complex logistic regressions that is modeling the risk of every single disease as a function of every single attributes that we've defined for our agents. And in the example here, I'm showing the equation we use to model the risk of developing CKD for our simulated agents as a function of calendar year, their age, their CD4 count at ART initiation, their BMI changes over time, and prevalence of all the other comorbidities in the model. And basically at each simulated year, if the agent doesn't have CTAD, they will plug their values into this equation. They will evaluate their risk. We flip a coin to decide whether or not they develop the disease or not. And we do this every year for all of the agents and for all of the diseases. And all of these functions have been evaluated and validated against an ACORD data set. So here is the full construct of the model, and the main outputs that we're projecting over time to year 2030 that I'll be focusing on today is the age distribution of this population, people receiving ART in the US, and also their comorbidity prevalence and multimorbidity burden. So before we move on, going back to that first principles of translational epi, not only we need to choose right methods, we need to be able to validate and generalize them. So how do we do that for the case of computer simulations? There is a vast literature on model validation. We performed several tests starting from internal validation, which means comparing pair projections against the data from an ACORD that was used for parameterization to make sure there was no bug and to verify how these functions and parameters have been defined in the model. For example, we compared the incidence of every single comorbidity for every single subgroup against an ACORD, where in this very crowded figure, those tiny blue lines that you're seeing are the projected incidence of different comorbidities for our subgroups. And the black lines mark per projections, and the shaded area around them are the 95% either confidence interval or uncertainty range. And since it didn't make sense to compare them exactly for each year, we came up with this clinically significant deviation, which means that we identified instances where our projections 70% or more of our projections were outside of the boundaries of the observed data. And happily, in this case, there was no instances. But this sort of like comparison helped us making sure that an ACORD data was evaluated correctly and was used correctly, and our projected outcomes for the duration of calibration basically match those findings. And we did also carry some external validation where we used data from CDC that was not used to inform our model to compare against our projections, for example, for size of population aging with HIV and their age distribution in different years to find a close match between our projections and CDC data. So now that we have this, extensive agent-based model, and we are hoping that we can, trust outputs, it's the fun part. We can start projection. So we first started looking at the age distribution. What is happening to this population over time? As we expected, population is aging. And in the figure, you're seeing the age distribution for 3 selected years back in 2010, shown in blue, where the median age was 46 years, down to red, which is the age distribution in year 2030. Now the age distribution is projected to go up to 52 years. And you also notice that the shape of age distribution is changing from that unimodal distribution to a bimodal distribution, representing 2 groups of patients, basically those who received earlier version of ART and are now surviving to older ages, and newly diagnosed cases who are starting ART at earlier time since diagnosis. And especially on the right side of this distribution, you'll notice an increase in how fat that distribution looks like toward the end. And we are actually projecting a 6-fold increase in number of people aging over 75 years from 2020 to 2030. So there is a significant increase in number of older individuals living with HIV who will be requiring services over the coming decade. Breaking down the age distribution by the 15 subgroups also goes as expected. There is a lot of disparities in the patterns of aging. There are some subgroups, including white MSM, heterosexual males, and Black and Hispanic IDUs that experience the majority of aging process. And among white MSM, for example, we are seeing more than 10 years increase in median age over time. And in comparison, there are subgroups such as Black and Hispanic MSM who are not seeing much of a change in age distribution. And it's not surprising because these are the two subgroups bearing more than 80% of new infections that is mostly concentrated among younger individuals. So they have this influx of younger new diagnoses coming in every year that is keeping their age distribution is still concentrated at younger ages. So now that we have a better understanding of the aging phenomena that is happening, we can start looking into the comorbidity burden. And since there are a lot of lines, let's walk through them one-on-one together. So the two green lines represent our mental comorbidities, starting from depression that has the highest prevalence across all projection years and stay high, higher than all of the other physical comorbidities. And this is diagnosed as having a major depressive disorder. And it could have been once, but since that diagnosis, the patient is living with the history of that major depressive disorder. And several studies confirm that these patients require to be receive a screening and access services to make sure it doesn't happen again. And for anxiety, I think it was we've defined it as first diagnosis with generalized anxiety disorder. And we are projecting a significant rise in prevalence of anxiety as well. Then the second group of lines are, marking the hypertension that has started around 40%, and we are seeing a slow reduction over time, whereas our metabolic diseases, diabetes, CKD, and hyperlipidemia are still on the rise. And finally, our latest stage diseases, cancer and ESLD, are remaining stable, but we are seeing that increase in MI that is following diabetes and chronic kidney disease as well. But let's look at the subgroup specification. That helps us understand some of these trends more. And since there are a lot lines here, I will focus on two main subgroups to discuss the implications. Remember the white MSM, they are one of the biggest subgroups among the 15 subgroups that we are modeling. A lot of national trends that we are presenting are basically representing white MSM because of their sheer large size. And this is one of our oldest subgroups experiencing more than 10-year increase in their median age throughout their entire projection period. And among this group, you still see, high burden of mental comorbidities up top. That's not surprising. They have a high rate of dyslipidemia, and we are also projecting a substantial increase in rate of diabetes and chronic kidney disease. The rate of hypertension is slowly reducing. It's following the rate in general population in recent years that is going down, which is great. And cancer is also stable. And among people with HIV, I think prostate and lung cancer are the most common. And one of the studies that Keri actually suggested and I looked into was showing the protective effect of aging for men over the age of 65. They saw a reduction in risk of new prostate cancer. And since this population has a big fair share of, white men aging over the age of 65, that's basically acting as a reduction in risk of newly developed cancer for them. And there's also studies showing the protective effect of ART on lung and anal and liver cancer as well. So that's why you're seeing that a stable trend in cancer rates. And unfortunately, we still have, an increase in MI, but it's not surprising in the context of diabetes and CKDs. So a lot of, the trends that we are seeing here is reflecting what's happening in general with our population, even in absence of HIV, and it's also reflective of the lifestyle and wide array of factors from physical activities to diet to smoking prevalence and alcohol consumptions among this population. Now, a more interesting comparison can be made with Black women who inject drug. And now, instead of talking about a big populations such as white MSM, we are really talking about one of our smallest subgroups that are not well represented in any of our national estimates. They have a significant amount of aging as well. By 2030, their median age was about 66. So that was the oldest median age that we were projecting across the 15 subgroups. This is a small population with limited resources, generally childcare responsibilities, lower access to care compared to white MSM. And among them, we still have those high burden of mental comorbidities, but it's kind of like overshadowed by this high rate of hypertension, with over 60% of them being hypertensive, and a very significant increase in rate of dyslipidemia, CKD, and diabetes over time. Again, reflecting a lot of underlying factors driving, their patterns of access to care, their lack of physical activities, their diet, exercise, maybe level of untrust in care that would affect their treatment adherence for these comorbidities as well. And now moving on, you can pull now all of these comorbidities together to develop different measures of multimorbidity. And the reason we keep talking about multimorbidity is that providing care for these multiple comorbidities at the same time is very complex, even for patients without HIV because of drug interactions. So it's important to understand what proportion of our population have several conditions at the same time and how this proportion is changing. So it's helpful to be prepared, as I'm sure, our policymakers have it in mind. For the purpose of this projection, we have a very general definition of multimorbidity. So 2 or more physical comorbidities among the mix that I showed you. And in this figure, you can see the proportion of our population with multimorbidity increasing from 38% in 2020 to 45%, corresponding to roughly 250,000 people, 250,000 people in 2020, increasing to 400,000 by 2030. So that's a big increase in terms of resource needed for caring for these multiple conditions. Part of this multimorbidity burden, especially when you break it down by the 15 subgroups, is due to the aging phenomena that I keep talking about. The population is aging. We know people at older ages experience high risk of comorbidities, so it's not surprising that we are seeing more multimorbidity over time. But even when you break down the multimorbidity burden by age and you look at the age-specified rates across different age groups, you'll see that pattern of increase over time. So among people, for example, age 60 to 69, back in 2020, about 58% of them were multimorbid. But by 2030, among 65% of them will be multimorbid. So this reflects that all of the increases that we are projecting is not due to aging. There are underlying factors, whether it's social determinants of health or physical activity or smoking or alcohol consumption or something else that is driving this increased risk of developing comorbidities among this population over time. Where are we taking these results? We are hoping that these results can inform, 3 groups of main audiences. First is the clinicians providing care for panels of HIV patients to have a better understanding of the risk for different diseases so they can screen them more for those diseases and provide preventive measures for other risk factors that drive the risk of those diseases. HIV clinical directors running the programs or HIV clinics can benefit from these sort of projections to select CME topics for clinicians and also identify subspecialties that could serve their patient population better, including geriatric care. And finally, at the a state or federal level, policy decision makers can use these findings to better prepare for the needs of this population aging with HIV, and especially breaking down these estimates, hopefully in our future grants by different states in the United States can help us better allocate funding in different states given the differences in population demographics. Now, going back to the principles of translational epi, I touched base on some of them through our previous work, but we're really trying to align our future work more aligned with these. So in the R01 that Keri mentioned that was submitted back in May, we are proposing an integrated simulation for basically following individuals from the onset of HIV infection, so modeling HIV transmission, linking it to the full cascade of care, and following these individuals throughout their entire lifetime until death. So giving us a complete picture of HIV epidemiology in the US, and we are proposing to break down this model separately for each of the 50 US states so that we have a separate picture for different locations, given the disparities in social determinants of health that are driving a lot of estimates that I presented today for our 15 subgroups. We talked about public health communication. How can we engage with, experts and public health officials and people who can both contribute to this research and also benefit from it? And we've found that a good way of doing it in the context of our ongoing grants is by engaging a scientific steering committee. We've invited a great panel of, experts ranging from clinicians to HIV clinical directors to federal, policymakers, Dr. Laura Cheever from HRSA, to join this ongoing proposal, agreeing to meet with us, on quarterly basis to engage them, in the process of model building, running the assumptions by them, getting their understandings of their questions of interest, and incorporate that in the early process of model building. Not only it helps us to elevate our work and, find the obvious flaws in our approach, but also helps them to understand our modeling methodology better, to trust our work more, so that by the end of these grants, they would, help us interpret our findings and take these findings and help us with disseminating through their network so that we can use, more people can use these findings, and hopefully there is a more direct means for translating it into changes in public health practice. As far as education, we have access to several tools today, thanks to the technology. We've tried to leverage Pell website as a resource for students and researchers and anyone accessing our publications to basically lay out the blueprint of the PER model. All of the modeling assumptions, data sources, our validation tests have been laid out in details on our website, and we will continue to keep it up to date. Our Git repository includes snapshots of models accompanying different publications, and the purpose is really make it reproducible. So anyone taking the time and the burden of downloading that code will be able to run it and basically reproduce the same results we presented in different papers. And I, as a modeler, I know this is a great thing because that's how I learned modeling, by downloading everybody else's model and looking into them. And developing an online toolkit is something we propose as a part of Inspire, because we have a curse of multidimensionality in this research. We are modeling 11 different comorbidities for 15 subgroups. It's very hard to represent everything in limited number of figures and tables. So having access to a user-friendly tool base that is available online helps our user to customize, visualization based on their needs for different subgroups, and design new interventions and give them full flexibility to basically navigate our findings. As far as implementation and community involvement, our work is a little bit away from these areas by the fact that this is a very high-level research looking into patterns in data and trying to make sense of the impact of hypothetical interventions in the future. But we are trying to push it toward, real-world implementation for as much as we can. So we are partnering with Dr. Judy Courier from ACTG, who was very interested in the idea of risk factor interventions. The BMI and smoking risk factors that are included in our model can be intervened upon to reduce the risk of future comorbidities. And we don't have any clinical trials looking into, for example, BMI interventions for people with HIV. So she's very interested in taking some of our projections and informing a future clinical trial for these subgroups. We're partnering also with New York State AIDS Institute, working on a model of HIV transmitted aging in the New York State to help them prioritize some of their existing programs for people aging with HIV, and maybe even launching some new pilot programs. Jules Levin, you may have heard of him or know him more than I do. He's great. I've been in touch with him through several talks that I've had here and there. And as soon as a new publication comes out, he contacts me. He's been living with HIV, advocating for people with HIV, and he's so unhappy with the state of HIV care and aging with HIV. So he's been both an inspiration for me to know that we are working on the right question, and he's been a great help in disseminating some of these results and speaking to their importance at different meetings. And of course, none of this would have been possible without having a very multidisciplinary, great team of experts on the team, led by Keri Althoff, who put this grant together and brought this team together in the first place. as I mentioned, again, I'm an engineer and data scientist, and a lot goes into build of this model, both from like the coding and a statistical, analysis, but also having a clear vision about the epidemiology and the intricate complexity of aging with HIV and inference of findings. And we were quite lucky to have Keri on the team. She is the co-PI of the NA Accord grant. She knows everything that's going on with that data set, that has been the full force behind all of the projections that I'm presenting today. So with all that being said, models are dynamic and ever-changing, and we've been working on this model for over 6 years and hope to continue working on it. We really evaluate your feedback. I mean, we value your feedback and hope to be able to incorporate it in future versions. So thanks for the opportunity to present. And I look forward to answering questions and receiving any general comments you may have even after the talk.
Any questions from the group here? If so, please go to the mic. So that the online folks can hear too. Is there any, Fran was asking everybody online any questions. Yeah. Can you come up?
Yeah.
Thank you so much, Parastu. Can I just make one quick comment before our questions start? It was wonderful. I loved particularly how you mapped your activities with the goals of translational epidemiology. I think that is now the gold standard for all of the talks going forward. So I love that. I thought that was a really great element. So thank you for doing that. Okay, well, we do have a question. We have hopefully a couple of questions here in the room. If anybody in the chat has any questions, please feel free to put it into the chat, or you're welcome to unmute yourself. But let's have Dr. A.
So, yeah, no, thank you. Very impressive work. Wonderful stuff. And I was just curious how the models might incorporate changes in the diagnosis of particular comorbidities that you're interested in. So, for example, I think it was in 2017, the AHA changed the blood pressure guidelines for classification of hypertension. And that's, right in the middle of the timeframe that you're looking at. And I'm assuming that some of the comorbidities that are detected are just simply they have hypertension. You may not be able to reclassify them retrospectively, but I could be wrong about that. Another one was, I think it was around 2010 that the hemoglobin A1C became a diagnostic criteria for diabetes. And this is a test that is now very common. I don't know how common it was, say, back in 2010 or 2012 for this population. So I'm just curious how you deal with changing diagnostic criteria for the comorbidities that you're interested in.
So I tell you my understanding, and Keri, feel free to jump in. I was actually reading about the hypertension case for general population this morning on a paper that was based on ENHANCE, and they didn't see a bump as they expected because they were relaxing the definition we would expect to see that bump. For some of the measurements in NA for Keri, I've seen that we have the lab measurements, so we can go back and refine our diagnosis criteria for them. For some others, we are relying on the diagnosis note from the doctor and also received of medication. So I don't know if we can change those.
Yeah, it's a great question, and it's something we work on a lot in the NA Accord. So as the data grow in their complexity and as our data sharing has grown, because, we're federally funded, we want to be sure that we share these data, but, sometimes people get our data and they're like, whoa, that's a lot of data, right? And so we try and provide best practices, right? So one of the things we do is we do have a kind of a menu of what we call our operationalized definitions for some of these comorbidities. So for hypertension, the guidelines may change based on blood pressure measurements. Interestingly, blood pressure measurements, not easy to get out of an EHR. It's shockingly complicated sometimes to pull those measurements. And it's not just at any one place. We're talking about at multiple healthcare facilities all over the country and Canada. And so Instead, how we measure hypertension is we look for antihypertensive medication prescription, because anytime you like antihypertensives work pretty well, very low side effects. So a lot of people are treated. There isn't a lot of like watch and wait with hypertension and lifestyle modification and clinical practice. So if the guidelines change based on blood pressure, and it's now slightly lower blood pressures are now indicated for antihypertensive diagnosis, our definition, or antihypertensive medication, our definition protects against that. One of the things, because we're still just looking for that treatment, right? So we're treated hypertension is what we're talking about here. For hemoglobin A1C, when it comes in, just as you said, it's not really measured all that much. So our operationalized definition is highly sensitive. So it's a clinical diagnosis or a hemoglobin A1C suggestive, or an anti-diabetic specific medication, and there's a list of those, or an anti-diabetic related medication plus a diagnosis, right? So we're trying to capture the evidence of clinical recognition of this underlying comorbidity, but it's also important to note it is not biologic onset, right? We are the data generating mechanism for the cohorts that are contributing to this are people who are seeking healthcare and clinicians who are evaluating them. It's not like an interval cohort study where you're measuring these things over time and able to see biologic onset. And so it is complicated. I will say the biggest thing that concerned us with definition change was actually the removal of race in the EGFR equation, because then that changes things. But historically, that wasn't, you can't go back in time and reset that. So now this equation will suggest a slightly lower EGFR, particularly persons who are Black. And we won't see, different clinical changes, prescriptions and other things at the same rate that you would expect, because the clinicians didn't have that EGFR based off without race in the equation at that time. So there are pieces like that that get a little clunky, I would say. But overall, when we're trying to harmonize all this data and create these estimates, there's a little bit of finessing to get to a measurement that is at least as consistent as we can make it over time, and just downstream from some of those changes so that we don't feel all of the bumps in the changes. But what we used in 2017, we do evaluate these operationalized definitions with clinicians and with researchers. Now we're doing it on an annual basis. And so that does play into this, that these definitions may change. So in 2017, it was the definitions that we had in the 2017 data, and we're looking to update everything in the model. So it'll be the definitions we're using now.
Thanks. Great answer. Any questions? Yeah, please feel free.
Hi, thank you. That was a really wonderful talk. At the end, you talked about using these results to motivate further controlled trials to reduce certain risk factors and see how that impacts incidence of comorbidities in this population. I was curious if you could speak more about whether you can use the Pearl model to model the effect of a hypothesized intervention. For example, if we shift BMI in a favorable direction or increase appropriate prescription of statins, can we, for example, reduce the expected incidence of heart attacks? Can we answer those types of questions?
Yeah, that's basically the aims of our first R56 that was funded 2 years ago, and we're working on that. Hopefully, we'll be publishing it soon. So I presented the preliminary results of a similar intervention to the one you mentioned, changes in BMI over the first 2 years after ART initiation, because that's the period where we see a lot of increase in weight among the NA4 participants. And we think that's that increase in weight that basically sets them up for an increased risk of diabetes and other diseases down the line. So the hypothetical intervention was, for the sake of being hypothetical, was formulated in 3 ways. Focusing on individuals starting ART, at normal or overweight BMI and passing into obesity in 2 years. What will happen if we control their weight at a threshold right below obesity? What will happen if we don't allow them to gain as much weight as earning, like going into the obesity, but just 5% of their original weight, because depending on how light they start, 5% translate to different pounds. And what will happen if nobody even gained weight? So that's like the most optimistic case, that we could retain the initial weight at ART initiation over the first 2 years. And we basically experimented with these cohorts in the model to map future reduction in rate of diabetes, and projected, significant reductions, but most importantly, wide disparities by race and by risk groups, AKA the need for such clinical trial to take place and have representation of different races and different, risk categories, to basically capture their underlying factors that is going into their weight increase and the potential impact of these interventions for their diabetes risks. But that's exactly how we envision the role of PARA in the future grants, basically from an explanatory tool that we've used so far just to project future trend to become an experimental tool that we can play around with different interventions.
Parastu, do you want to talk a little bit about the comparison with Katie and Katie?
Yes, yes. Oh, so in the context of the same, BMI intervention I mentioned, one of the problems with using simulation models such as this is that we are observing correlations between different diseases. We know diabetes is accompanied by CKD and by hypertension, but is there a causal relationship between them? We know among people who gain a lot of weight, there is a lot of diabetes, but is this enough to prove that reduction in weight would reduce, risk of diabetes as well? So there is always that chicken and egg question, which is why we are coupling this exercise that I just mentioned with a causal inference exercise that Kate Lisko is leading to basically use the same data set that we've used to inform the model and set up the causal inference analysis for reduction in risk of reduction in BMI at ART initiation, and its potential impact on reduction in risk of diabetes. That piece is still in progress, but we are very excited about it because if hopefully our projections align or are close enough, that helps us to defend the sort of projections that we are making in parallel. And it's also an innovation, kind of like from the methodological standpoint, it's a very innovative and it's been a learning process for both of our groups coming from different perspective into the same headspace to use different approaches to model risk of, these different diseases and their potential impact. I'll be excited to see how the results look like. Other questions?
Just even see if there's any
I'm looking at the chat.
We don't have anything on the chat. Just Dr. Cooney's great talk.
great talk. Any last minutes? All right. Thank you very much. This was wonderful. Look forward to hearing more about it. You'll have to come back and give us an update. And with that, good luck on finals for all of the students and have a wonderful summer. And we'll see you in September.